now we're going to go deep. We're going to go deep into the deep back, just like we talked about. So this is a summary from last time. This is where we've been. So we've talked about superficial and intermediate layers. These are the muscles we've discussed. So I like this picture just because it shows you the layers that we have to manage and deal with here. So dealing before with the superficial extrinsic muscles, we saw trapezius, remember that kite-shaped muscle. If you were to cut trapezius away from the spinous processes and you were to flip it back, it would look something like this. So you would see the rhomboid muscles underneath there. So I can see the rhomboids. Remember, those are important retractors of the scapula. Up here, I see levator scapulae. So we mentioned that guy too. So that's going to elevate the scapula. We also talked about this one, which has been cut away from its origin along the thoracolumbar fascia. So this is the latissimus dorsi. That one's been cut. These reveal the intermediate compartments. So the intermediate compartment I see here. So serratus posterior, superior, and inferior. And then we dealt with some of the shoulder girdle in the last. So what we'll do now is we're going to dig behind this fascia and find the deep compartment muscles. So we'll find these deep compartment muscles, and we'll talk about some of these deeper muscles in the neck. That's the goal for this particular lecture. So in order to do that, we really need to recognize this first important fascial entity here. This is an extremely complicated fascia, actually. So this thoracolumbar fascia that you see back here, this shiny, bright white fascia, it does look like this in the donor. Usually can be pretty aggressive in this dissection, just stabbing all the way down till you feel spinous processes, get that superficial fascia off. Once that fat comes off, it's just this brilliant, I've never seen one not look this way. It's just brilliant, just pearly white fascia, this broad, really big attachment back there. Thoracolumbar fascia. So this specific, most posterior portion of the thoracolumbar fascia where the laser is right now is specifically right here. Okay, so this is that posterior layer. So that posterior layer is covering the deep back muscles, which we'll discuss. So this is a axial section, right? So we can see the section's been taken through it right here. But technically, the thoracolumbar fascia actually does have other layers. There's a middle layer, and there's an anterior layer as well, which will encircle a muscle called the quadratus lumborum muscle. Don't really need to know about that muscle now. It's more of a muscle for the abdomen. But nevertheless, so the thoracolumbar fascia, we've got to talk about it somewhere. So it's kind of encircling that QL muscle there, quadratus lumborum, anterior middle layers, and the posterior layer will be our big focus here for now. All right. So this is the intrinsic back. So the intrinsic back, we've got a few more muscles to deal with here. Some of them are pretty tiny. We may breeze over a few of these, and I may just give them a faster mention. Try to focus on the ones that are a little bit more important for our purposes. So we'll start with one that is important for our purposes. So the first important group that we'll talk about here is the spinotransversalis group. So the spinotransversalis group includes basically one muscle that's split into two parts. So it's one muscle split into two parts. So we'll see the splenius. The splenius muscle has a portion that inserts onto the head, so we call it capitis, splenius capitis, like a baseball cap, so it's derived from the same word. Then we have a portion that's attached to transverse processes on the cervical vertebra. This is splenius cervicis. So splenius capitis and splenius cervicis. And the way the picture is showing you here, it shows you one on either side, but of course you would have both on both sides. So in this picture, you can see the one attached to the head, capitis, and the one below, splenius cervicis. So when the early anatomists were peeling people open, they could see that this particular muscle has almost a diagonal sort of trajectory. You can see it going sideways here. And the early anatomists thought it looked like someone had just laid a Band-Aid across the back of the head. So splenion, this means bandage. So if you were to fire the splenius muscle here bilaterally, so you'd have some on the other side as well. So if you were to fire this muscle bilaterally, then it would help with extension. Okay, so it would help extend the head and neck. But you could just use one and not the other. So you can imagine if you were to shorten these fibers here, splenius capitis and splenius cervicis, and you're only using one side, then the head and the neck will rotate around. Does that make sense? Could you see how you would do this? It would help rotate the neck around and the head around like this. And it would rotate to the same side as the muscle. Does that make sense? So this person's head, if you were to fire these muscles, this person's head would rotate to their right. So since the muscles are on the right and the head rotation is to the right, we'll introduce a term now. We call this ipsilateral. So that's another anatomical term. So the head is rotating to the same side, or the ipsilateral side of the muscles. If it was going to the opposite side, we would call that the contralateral side. All right, so splenius, very interesting and important little muscle here. All right, so that's it. So that's the only one in the spinotransversalis group. So thank goodness for that. The intrinsic back muscles also have an intermediate layer. So there's an intermediate layer within the intrinsic back muscles, and we call this the erector spinae group. So the erector spinae group, they're pretty important. We need to know these. There are three major parts. You can see if you were to appreciate the general trajectory of all these muscles, you can see they're pretty close to the midline here generally, right? You can see them coming up and latching on to things like the ribs, higher levels of the vertebral column, just like this. Their general function is to extend the spine. So this is why they're called the erector spinae muscles. So if you were to fire these muscles all together and your spine is in flexion, like this, your spine is in flexion, and they all pull, they're all just kind of pulling you up at one time like this. This is the extension of the spine. There are three parts. So the iliocostalis is the most lateral portion of the three. Iliocostalis, as the name implies, you're going to have a little bit of attachment down here from the ilium, so this hip bone, a little bit on the sacrum as well, so origin. You can see the reaching up to ribs. So the anatomy term we use for ribs, costum, so referring to the ribs, the costal cartilages and costal margin. So if you see costal, you're thinking about ribs. All right, so iliocostalis. If you go medial to iliocostalis, we'll see one of the longest muscles in the body. This is the longissimus muscle. The longissimus is the longest of the three. And that's literally, that's what it means. It's Latin, it means the longest one. So the longissimus muscle will start also all the way down here on the posterior aspects of the sacrum, work its way up, attaching along ribs like this. It'll attach along some cervical verts, and actually goes all the way up and attaches on to the mastoid process. So the mastoid process is a feature of your temporal bone. If you feel behind your ears, like basically behind where your earlobes are, there's two bony prominences there on either side. That's the mastoid process. Important for lots of attachments, and the longissimus muscle happens to be one of them. If you go medial to the longissimus muscle, then you'll see the final of the three. This is the spinalis muscle. Okay, so the spinalis muscle is very, very close to the midline, and its origin and insertion are spinous processes. So the origin will be coming from more inferior level spinous processes and attaching to more superior level spinous processes. So it's just going to pull on these higher level spinous processes and help with extension. All right, so all these guys at the end of the day, they're just helping with extension, spine extension. And from lateral to medial, remember, I love spinach. Iliocostalis, longissimus, spinalis. Erector spinae. So just some actions here, the spine. So this is a stretch I do every morning when I get up. This person's face. Wow. You're like dead inside. Like, what am I? Wow. My face probably looks like this every morning too. Roll it a bit. All right, so what this is demonstrating is a person in flexion going in, or a person in extension going into flexion. So the arrows are simulating what flexion would be. You have a couple of muscles that can help with that. Some of them you may have heard of. So the rectus abdominis muscle, some of your belly muscles here will help with that. You have a hip flexor here that's important. The psoas muscle, it can help with that as well. And then, of course, the ones we talked about. So the erector spinae muscle, they're doing most of your heavy lifting when it comes to extension. There's a few other ones that can help, but the erector spinae, they're the most important. All right, there are other movements when it comes to the spine. So we have flexion, extension, like we just saw here. So you see this person, which is in flexion, going back into extension. And you can go from side to side, as I'm sure you probably noticed, right? You have some side-to-side movement like this. We just call this lateral flexion extension. So if you're going out here, we call this lateral flexion. If you're coming back, this lateral extension. So some of these muscles can help with this. Talking about just a concept really quick, because I will bring it up from time to time. So these different types of muscle contractions. So maybe Dr. Mahaney will get you more of this in other courses, but this does come up every now and then in anatomy. So just these different concepts of muscle of firing. So there's different ways that muscles can be active and therefore acting on the skeleton, and it may not always be so intuitive about how that action may be occurring. So the first one that everyone kind of thinks about when they think about muscles firing is concentric action. So concentric action, concentric is whenever the muscle is firing and it's animating the skeleton in some sort of direction, and the muscle is literally shortening. You can see the muscle shortening. So a good example here would just be like your biceps. So whenever your biceps is firing, it helps you with elbow flexion like this. So the skeleton is pulling the skeleton up, and the muscle itself is shortening. That's what it's supposed to be doing. But it's weird to think about, but you can actually do the opposite. So you can do eccentric contraction. So eccentric contraction is just the opposite. So if you're in like a flex position like this and you're going down, but you're controlling it, right? This is, we do this in the gym. I say we, but I go to the gym every now and then, but whatever, So eccentric contraction is when the muscle's still firing, right? So if I were to, if I was doing a negative, is what I go in the gym, you're just going down very slowly, you're still controlling it. Biceps still firing, but the muscle itself is lengthening in the process. But it can still work. It's not like you just drop straight down. So that's eccentric contraction. And then you can kind of reach some sort of middle where the muscle's neither shortening or lengthening. We just call this isometric contraction. Okay, so just a little bit of terms there. I hate doing vocabulary, but these are terms you may hear myself or Dr. Beeger talk about throughout the course. So, all right, so moving on then. So we just talked about the spinotransversalis group when it came to splenius. So now we'll talk about the transversospinalis group when it comes to these. Yeah.
Sorry, I didn't want to interrupt.
That's fine.
Can those, so like, if you're doing like the movements, can muscles be doing the opposite of what another muscle is doing? So like if you're shortening, can another muscle be lengthening and vice versa? Yes. So in fact, so muscles have relationships usually in groups. Mm-hmm.
So they'll have like agonist antagonist groups. Usually is what they'll say. So if you're for example, with biceps like this, if you're flexing your biceps and you're bringing your olecranon process forward like this on the backside, then you're by definition extending the antagonist group, which is the extensor of the triceps on the backside like that. So usually if they have an antagonist sort of relationship with another muscle group, which is often the case, then if you're shortening one, you have to be lengthening the other. So they're in this never-ending sort of democratic balance. Yeah. Good. All right, so transversospinalis group. So the transversospinalis group are, unfortunately, a little more complicated, I guess you would say. So we talked about splenius. So we did splenius capitis, splenius cervicis. So now we'll talk about semispinalis. So the semispinalis muscle will have a couple of different parts. There is a small thoracic portion down here at the bottom. The ones we'll focus on are the cervicis and capitis. These are really the most important portions. So what we'll see from these, I was thinking about the cervicis portion here, is the muscle generally coming from transverse processes, arising from transverse processes, inserting onto spinous processes like this as its insertion. For the capitis portion, you'll see actually insert onto the back of the head. Okay, so if you were to use these muscles, the semispinalis muscles like this, bilaterally, if you're using them at the same time, on the neck and on the head, then you would extend, just like you saw with splenius. So it's just going to be just bilateral, just sort of extension like that. But you can use them on one side. So if you're pulling in this sort of direction, this is worth our time to talk about. So if the origin is like over here on these transverse processes, and it's pulling on the spinous processes right here, then the direction of pull is essentially this direction. Does that make sense? So it's possible to use the semispinalis muscles unilaterally, and if you use them unilaterally, then you rotate to the contralateral side. Does that make sense? So before we talked about the splenius muscle. The splenius muscle is pulling this direction, so the head would rotate around this way. So the head would be moving from to the right. Okay, and this is the splenius muscle on the right. So this is the semispinalis muscle on the right side. But if it's pulling this direction, then the head and neck would rotate the opposite way. So this is a contralateral rotation. Okay, so ipsilateral for splenius, contralateral for semispinalis. And again, for both groups, if you use them bilaterally, then their rotational effects cancel each other. You just extend your head and neck. All right. I'm okay. Good, huh? All right, wow. It's a disaster. All right, so we're going to continue in this group. All right, so the transversus spinalis group continues. So we have there's three muscles in the transversus spinalis group. So we started with semispinalis. Now we move into the multifidus muscle. Multifidus muscle, fun muscle. We like this one. So the multifidus muscle, you'll see it would come all the way down here on the sacrum, and you'll see it run all the way up to about C2 vertebrae. In fact, that's where it ends with C2. So the C2 vertebrae go all the way up. So the multifidus muscle is very similar in its rotational and extension effects. Because it's part of the transversus spinalis group, most of the direction of its pull is similar to that of the semispinalis group that we just saw. So if you're to use the multifidus muscle bilaterally, you're just going to extend the spine. Right? It'll help you with spinal extension, just like the erector spinae would. But since you have that sort of sideways pull, so arising from generally transverse processes and inserting generally onto spinous processes, then you would have a contralateral rotation. So that could help us with contralateral truncal rotation. The multifidus muscle is an important postural muscle. It has it's thickest in the bottom, just like you see here. So it gets kind of thinner as you work your way up. It has a lot of replicate motor units on the inside of it, so the neurons that are innervating it, when one group gets tired, then another group can pick up, so they're important for your posture. And we see it all the time in labs. So our donors, fortunately, they're usually older. They live long, healthy lives. They die at old ages or natural causes or whatever. But a lot of them do spend a lot of time on their back before they die. And because of that, their postural muscles, they don't get a lot of exercise, so they're laying in bed all day. And because of that, the muscle itself will begin to sort of deteriorate and break down if you're not using your muscles, and it will involute with fat. So there's a lot of times I'll cut through the tendon of the erector spinae, look underneath there, and the multifidus muscles it may have some muscle fibers in there, but it's not a brilliant, bright, nice muscle. Will have a lot of fat that's in there, and that happens with all muscles. But multifidus is one that you see a lot just because it's important for posture. All right. Good. And then the final in the transversus spinalis group is the rotatories muscles. So the rotatories muscles are tiny. They're very small little muscles. You can see they're very deep, so they're all the way down. They're very close to features of the vertebral column. They come in two flavors. There's a long one and a short one. So the rotatories longest, coming from transverse processes out here attaching centrally, going 2 levels, so we'll skip 1 level, and rotatories brevis will just go up 1 single level. Okay. So that's how they work. So they can help with little local adjustments to rotational movement. So just like with the other ones, they're able to do contralateral spine rotation if you're using them unilaterally, or extension if they're using them bilaterally. So not too terribly important. So that one will be a little lower on the list for us. Probably the lowest on the list for us, but just more of an FYI, are these 3 muscles. So there is a minor deep layer all the way back there. You can catch these in some imaging sometimes, and you'll see them sometimes in dissection. But you have 3 little smaller muscle groups in this deep layer. One that you'll see between transverse processes, they call these intertransversarii. So the intertransversarii between transverse processes. You have a few between spinous processes, they call these interspinales. That's a good name for it. You would see these kind of in the same area where you would see the interspinous ligaments that we talked about in the last one. So they would kind of flank the interspinous ligaments on either side. But they're tiny. And then last but not least is the levitories costarum. So you can probably guess the action of levitories costarum would be to elevate the ribs. So the levitories costarum, they are a little bit small, so they would come from transverse processes and attach onto the ribs down there. And so when they shorten, they would have some small effect at least on elevating the ribs. So 3 smaller muscle groups. I wouldn't sweat these too much, just more for completion's sake that we would talk about these. Okay. Now you may have noticed that I talked a lot about all those muscles, and there's a lot of muscles, and I didn't mention a single nerve. And there's a good reason. You'll be thankful for it. The reason, they're not innervated. No, I'm kidding. They have innervation. But they're all innervated by the same thing. So that's really nice, so you don't have to remember a different nerve. I showed you this picture last time. So remember, I showed you a picture of the spinal cord. We saw the ventral root, dorsal root, spinal nerve. We talked about the ventral ramus, and we talked about the dorsal ramus. This is where the dorsal ramus shines. This will be the only time we talk about dorsal rami, I think, in this whole class. But the dorsal rami, they're a mixed nerve, so that means they're going to carry motor signals out to all of these deep back muscles we talked about. So all these deep back muscles I just mentioned, they're innervated by dorsal rami, period. That's it. You don't have to know the levels or anything like that. Praise the Lord. It's great. The dorsal rami are also sensory in nature, so you have some sensation coming back from your muscles to tell your brain about where your muscles are in space and stuff like that. And they do the skin. So if you were to reach back and scratch your back right there and you can feel it, you can thank your dorsal rami for that. So they do a little bit of skin sensation as well. All right, great. So that's a big win. That's a huge win. Dorsal rami doing all of this. So whenever you're dissecting, whenever you take the skin off and you're getting through the superficial fascia, you run into all of these little sprouts. So all of these little derivatives of the dorsal rami are literally just blowing through these muscles. They're not innervating them, right? They're innervating only the intrinsic back muscles, which, well, that's not one. It would be deep down. I can't even see them here. But these are the extrinsic muscles we talked about in the last lecture. They just shoot right through them. They're just going all the way through because they have to get to the skin as well. So the medical students, they'll cut in there and they're like, what is all this? Do I need to know this? This looks important. Do I need to know this? And I'm like, there's dorsal rami. You can cut it. And they're like, okay. So that's it. So that's the whole story with dorsal rami. Another important point we'll introduce now and torture you with later is the concept of dermatomes. Has anyone heard of dermatomes? You've heard of this? Yeah? Okay, sorry. So I have to talk about dermatomes. They're super important. They're just so important. So clinically, it's a big, big deal to know these dermatomes. So it's a skin cut is what it is. Dermatome is referring to a cut of skin. Your skin, it's actually convenient. I'm glad it's like this. But your skin has a very orderly sensory innervation pattern to it. So you're essentially innervated like a zebra stripes going all the way down. And every spinal level that we discussed, we talked about the spinal cord and all the different spinal levels last time. And so all 31 of those levels, except for C1, will have some sort of dermatome pattern here, a territory of skin that it's responsible for providing cutaneous innervation to. So with the dorsal rami, for example, so all the dorsal rami from all of these levels would just be covering the skin here, specifically over your back. Okay, so C2 is from the C2 dorsal ramus all the way down, so we'll talk about that in just a second. All right, so dermatomes. All right, so arteries of the intrinsic back. Another image I showed you yesterday, so nothing too new. So remember, the aorta is running on the front side of the vertebral column, giving off these segmental branches. We call this, in this case, they're called posterior intercostal arteries. After the ribs are done, segmental arteries keep coming off. We call them lumbar arteries. And you remember from last time that these arteries are helping to supply the spinal cord. And you can also see that these arteries will give off some blood supply to the deep back muscles that we discussed. So where I'm at right here with the laser is probably like your erector spinae muscles. The iliocostalis, longissimus, all those guys. So it's just helping to perfuse them. So the dorsal rami will help innervate them, give them their motor supply so they can move, and then these segmental arteries will help with their perfusion. So the ones we see here, these are posterior intercostal arteries because they're between ribs. Remember, below that we would see lumbar arteries, which aren't pictured, but they're just segmental arteries. You also have an artery in your neck called the deep cervical artery. We can worry more about its origin later, but the deep cervical artery would kind of help with the intrinsic back muscles in the neck region. Okay, so these are the three important supplies, arteries for the intrinsic back. All right, so just like with the last lecture, I gave you the little table, so same little table here. So we can see muscle, origin, insertion, action, and all the innervation is dorsal rami, so that works out great. All right, cool, a lot of muscles, a lot of muscles. Okay, so let's finish by moving up into the neck. There's lots of important stuff to talk about in the neck. So what we'll do first is actually focusing on the bones. So in the MSK system, focusing on the bones first will help us understand we're talking about origins and insertions and things. So the two uppermost cervical vertebrae, C1 and C2, they're a little bit different than the rest of the cervical vertebrae. In fact, they're a little bit different than all the other vertebrae. and they get a special name. So the C1 vertebra, where your occipital bone would sit on top, forming the AO joint, or the atlanto-occipital joint, we call this the atlas. Okay, it's just like Atlas, the mythology, holding up the world, all that. So that's the atlas. So the atlas is a ring. It's a very interesting little bone here. So it's a full ring like this, has these slipper-shaped articular facets. It's got, like any good ring, I guess it's got an arch-looking thing on the front, so we call this the anterior arch. It has a tubercle. More importantly, you see the posterior arch back here. It also has a tubercle. There's a little groove carved out of the atlas. I'll bring one on Monday so you can see it. This is an important groove where an artery would travel, actually. So the artery would travel right over the top of that, the vertebral artery. And lateral to that, I see its transverse process. So remember, we discussed last time, the cervical vertebrae are unique in that they have holes in their transverse process. The atlas is no exception, so this is a transverse foramen, which would help communicate that artery, which travels over that groove. All right, so that's our atlas. Remember, holding up the occipital bone. Inferior to the atlas is C2, and C2 is also called the axis. And you can see the axis, just at a glance, looks kind of similar to other vertebrae, right? It's got a lamina, it's got a spinous process, it's got a transverse process, but it's got this thing, which is crazy. This is the dens, or the odontoid process. So the dens is actually, embryologically, was supposed to be the vertebral body on the atlas, and the axis actually stole it from it. But it does it on purpose because we need these two, the atlas and the axis, to work together to help facilitate head rotation. So the dens here will actually articulate right there on the anterior arch of the atlas and form the atlantoaxial joint, or the AA joint. All right. Good. All right, so two important vertebrae there, C1 and C2. A little more on the atlantoaxial joint. So when the dens is fit into its position anatomically here, we buckle it down with a very important ligament. Okay, so this is part of excuse me. This is part of the cruciform ligament. So this particular aspect of the cruciform ligament is called the transverse ligament of the atlas. And if you're looking at it posteriorly, it looks like Netter did a little bit of a laminectomy. So he did a laminectomy, so you can see on the inside here. And I can see the dens is actually covered by this cruciform ligament. Specifically, the T part is the transverse portion. This keeps the dens approximated to the anterior arch of the atlas. So we want to keep that there. And you can see, since the atlas is just a ring, it can swivel around the dens and it'll help facilitate your head rotation. There are other aspects of the cruciform ligament as well. It's got other bands. That's why it's called this. So you have a superior and inferior band, cruciform meaning cross. And there are some alar ligaments in there which will attach the head of the dens up higher, so a little lower yield. All right, moving over here. So this is not the greatest x-ray for this. So we have basically a whole lecture of this in the next block when we talk about the radiology in the spine. But you can see this is an image here. So lateral x-ray of the spine. I can see the anterior arch and the posterior arch. It's usually kind of shaped like a D, in this case a backwards D. And the dens here on the axis would just reach up and make an articulation. This person, it's kind of obscured. You get a lot of hyperdensity there where all the bones, so since the x-ray is just a two-dimensional picture, right? So since it's just a two-dimensional picture, if you have a lot of layers of bones that are superimposed over each other, then you get a really bright hyperdense signal like that, so it may be difficult to read. But nevertheless, that's where it's at. All right, so on that note, talking about rotation of the cervical spine, so your cervical spine has quite a bit of rotation in it, and we talked about all the muscles which will help contribute to that rotation, right? So we have that whole ipsilateral, contralateral business to deal with. And notably, the big takeaway from this slide, really, there's a couple of big points. The first big point, which is a point I made on the last slide, is the AA joint. So this is the one that's going to help with rotation, like shaking your head no. So this sort of rotation here, so it allows you to kind of shake your head back and forth right here. So when you talk about the entirety of your cervical spine's ability to rotate, most of it, you can see here, overwhelmingly, most of it there is happening at the AA joint. So 40 degrees of rotation there at the AA joint. So that's one big takeaway. The other big takeaway is the AO joint. So you can see, if you see the top, let's see, The occipital condyles, they're kind of shaped like this on the bottom of the occipital bone. And this slipper shape here on the atlas is concave like this. It's kind of like this sort of look to it. So you can see that this concavity of the superior articular surface of the atlas would receive the occipital condyles, which are convex. So whenever you're shaking your head yes, like this, a lot of that rotation is happening, this extension flexion is happening right at the AO joint, right, atlanto-occipital joint. I actually do a lot of research in here. I submitted a paper yesterday, Journal of Neurosurgery, looking at the shape of this, so the articular facets in patients with Chiari malformation. So they have flatter facets. So they have a lot of, they're notorious for having atlanto-occipital. This is no yield. This is not going to be on your lecture exam. This is just me trying to pretend like my research is important. So this is C1 right here. So they don't have the same level of curve. The Chiari patients are really flat like that. So because of that, they don't have that nice tight pocket. They slide around a lot. They have a lot of craniocervical instability. Yeah.
How familiar with the degrees do we have to be?
0% familiar. I would just, yeah, that's a great question. That's a good question, yeah. I won't ask you about the degrees, but I would ask you, like, which one contributes the most. Yeah, I wouldn't ask you, like, which one contributes fourth most. That would be crazy. Which one contributes the most? So I would know, like, most of your no rotation at C1, 2, and you'd be okay. That's a good question, yeah.
So since the degrees of motion jump pretty far between those C1 and C2 and C3 and C4, I would assume to some degree there has to be some amount of like slack between the arteries or nerves that go in between those transverse foramen.
That's a great point. Yes, there has to be some give. And so all the vessels and all the nerves that are in there has to be some amount of soft tissue pliability to allow a healthy amount of rotation in there. Exactly. You're exactly right. You can overextend it, and that's why you see, these stories pop up about famous model got a vertebral artery dissection after a chiropractic visit. So they get a little more aggressive than the normal range of motion. But yeah, does that make sense?
Yep.
Cool. Yeah.
Is that joint the AA joint? Is that where like stroke patients? Like, does that affect them heavily right there?
You mean the AA joint being like here, or the AO joint being like here?
Like the AA, like they can't like really like sometimes they have limited motion now.
Oh,
Like,
it's-
having a stroke.
It's hard to say. I mean, my guess would be that they probably don't have as much as a mechanical AA problem. It's probably more of an MSK. It's probably more of a muscle problem if they're having motor issues on one side. People can have problems with that joint, so we'll talk about it next semester. RA patients with Down syndrome, RA patients particularly. If you have RA, then the atlantodental interval can be kind of a big deal for reasons I'm about to talk about. On that slide, we'll go ahead and talk about that. The reason why it's important is, we'll go back. The reason why it's important and that ligament's important, so that ligament can degenerate there, the transverse ligament in RA patients, is because it's great because your dens needs to stay buckled down to the atlas, but if your atlas is, to help you with rotation. But if your dens is not buckled down to your atlas, then your atlas can just sort of float away, right? It can translate anteriorly, like you see in this picture. So if your atlas is translating anteriorly like that, it's going to compress your spinal cord. Which brings me to Steele's rule of thirds. So Steele's rule of thirds is essentially what you should find in the ring of the atlas. It should be broken up by a third. So a third of the ring inside of the atlas here should be occupied by the dens anteriorly. A third of the ring should be occupied by your spinal cord. In the image here, you can kind of see it right there. It's a CT, so the bones are really bright. And a third of the area in there should just be empty space. It may be on either side of the cord, but if we're mathing correctly, this should be one. But so Steele's rule of thirds. So if you have some sort of issue with that, this atlas can translate anterior, compress your spinal cord, and this person would have sensory issues, motor issues, and this could be emergent. Going backwards, though, so if we're looking at these joints, there's a couple of other important blue boxes here. So we talked about the shape of the occipital bone on the atlas, that AO joint facilitating that yes movement. The shape of the atlas's superior articular surface is also kind of has a bank to it. You see that? So it's angled in kind of like this as well. So in addition to it being having a concavity, it's also banked in like that. So if you think about the pressure of your entire skull pushing down on this angled bank, the ring of this angled bank, if you are in a situation, notably diving into shallow water and hitting your head. So if you're diving into shallow water and you hit your head, and these compressive forces moving through the occipital bone are pushing that ring. And when they push that ring, if it's too much, then it will fracture the ring and it spreads open. So atlas fractures, compression-related atlas fractures, aren't always clinically dangerous because it's just spreading the ring open, like further away from your spinal cord, compared to some other fractures. Nevertheless, though, that can be a pretty serious issue. So they may have to go in there, and just depending on how displaced they are, they may have to fix, add fixation to these so they're not moving around. All right, so we call this a Jefferson fracture. So the mechanism here is a burst. So it's a burst fracture because you're compressing the vertebra below, which spreads that ring open and causes these fractures to occur. Another very commonly discussed fracture is a hangman fracture. So a hangman fracture is a fracture through the lamina, specifically the pars interarticularis of C2. It's just a laminar feature. So with this is just common in hyperextension injuries that you would see the pars fractures. Mm-hmm.
Is there any fractures in the neck of the dents? Like the dents fractures?
Yes. Yeah, so you can get, there's, I think, 3 different types of odontoid fractures, or like just the tip fractures, or fractures through the neck, or the fracture extends into the body. Odontoid fractures are actually very common fractures of the axis. Mm-hmm. So hangman's fracture, interesting little blue box there, clinical correlation. All right. So we discussed this kind of already. I got a little bit ahead of myself, but I'm having fun. So this is the AO joint. So the AO joint there, remember, this is the one that helps with shaking your head yes there at the AO joint. And that would just articulate with these condyles. So when you hear the term condyle anatomy, it's usually an articular surface. It's usually a bone surface covered in cartilage contacting another bone surface covered in cartilage. And that's what you would see here. So your occipital condyles would just rest inside of those facets there on the atlas and allow your movement. This is an interesting view. We'll talk more about next year in the anatomy imaging, or I guess technically next year in the anatomy imaging course. You stay around next year, not next academic year. You get it? Okay, whatever. So we can see this picture is actually a picture to look at these joints. So AO and AA joints to see. You can detect spread fractures in here, the burst fractures. But it's interesting because they ask the patient to open their mouth. So this is kind of a technically challenging series for the radiographer. So they ask them to open their mouth, and the central beam for the x-ray would go straight through, because basically right through the back of your mouth is exactly what you see here. So you see C1 and C2, you see the dens here popping up. So if your atlas is fractured for say a burst fracture, you have a lot of excess space that may hang over the edges and stuff like that. For us, that's good. All right, so we'll finish. We've got 10 minutes, so we'll talk about the suboccipital region. Someone mentioned this artery, and this artery cannot be talked about enough. I love this artery. I have a poster of this artery in my room at home. The vertebral artery is so cool and so important. So this is a vessel that would come from the subclavian artery, which is running downstairs here close to the base of your neck. And as we mentioned, the vertebral artery will traverse, literally passing through, usually starting about C6. I don't know why, but it likes to skip C7. Will pass through these transverse foramen within the transverse processes of the cervical spine, all the way up, all the way to C1. It'll poke into a little membrane here called the atlanto-occipital membrane that we see here, and it goes all the way into your brain. So this supplies your brain. So this is why having a stroke or a dissection to the vertebral artery could be bad news, because you can end up with what's called posterior circulation signs. So your brain is basically broken up into anterior circulation and posterior circulation. So posterior circulation would be things like your cerebellum. So you'd have ataxic kind of movements if you had vertebral artery issues. Also your occipital lobe, which is involved in vision. So you could have some visual disturbances with these sorts of strokes. So bad news. An important little nerve that you see pop through is the suboccipital nerve. Now the suboccipital nerve is just a named dorsal ramus. So this is just the dorsal ramus of literally C1. This is the very first dorsal ramus. And it's motor only, so it's supplying motor innervation to some muscles that we'll talk, some tiny muscles that we'll talk about. It's always squeezing its way through between the bone here of the atlas and the artery. So it's actually going underneath the vertebral artery to get out into the space here in the back of your neck. All right, vertebral artery, pretty cool. So on the subject of those muscles, so suboccipital muscles. So you could probably guess the location of these muscles. So they're below the occipital region. So our occipital bone here, here's our suboccipital muscles. There are 4 suboccipital muscles, and 3 of them participate in what we call the suboccipital triangle. I told you the triangles are coming, but it's like Sesame Street. Shapes for days. I mean, they're coming. They're coming. So yet another triangle. This is an important location here. So this is the C2 spinous process. So the C2 spinous process will be the origin for a couple of these muscles. This is the transverse process on C1, so we can see a lot of them, though, reaching up to attach onto the back of your head here. There are 4 muscles here. So the 2 that are coming from the C2 spinous process, one is the obliquus capitis inferior, and another one here, this is rectus capitis posterior major. The obliquus capitis inferior goes all the way over and inserts onto transverse process C1, and then from transverse process C1, we see the origin of obliquus capitis superior. So obliquus capitis superior, obliquus capitis inferior here, and rectus capitis posterior major. These 3 muscles make the suboccipital triangle. Medial to them, I see another suboccipital muscle, even though it's minor, so it doesn't play in the triangle. We see the rectus capitis posterior minor. So the rectus capitis posterior minor is coming from C1. Remember, C1 doesn't actually have a spinous process. It has a posterior tubercle on its posterior arch. So it's just going to come up and attach onto the back of your head. The actions of these muscles is pretty, it's not really big. In the overall movement of extension and rotation of your head, these aren't too great. However, this is just an important anatomical location. Even clinically, right now, I'm literally writing a grant to look at the thickness of the suboccipital muscles in patients with Chiari malformation, because they've done some rat studies that suggest they could be a little bit bigger because they think they're having craniocervical junction problems, which overwork their muscles and hypertrophy. My hypothesis is they would hypertrophy these muscles, so may contribute to some of their pain or cervicalgia. All right, so these are our muscles. This is everything laid on, kind of netter view. I like this view. Let's find our 3 muscles in the suboccipital triangle. So I see obliquus capitis inferior, rectus capitis posterior major, and obliquus capitis superior. So there's our triangle. And I get a little bit of a window to see rectus capitis posterior minor. A nerve that I mentioned, there's the suboccipital nerve. So the suboccipital nerve emerging from underneath the vertebral artery as it passes over the groove of the vertebral artery, right over the back of the atlas. So this is the posterior arch on the atlas here. 2 important contents. So when we're talking about contents of the suboccipital triangle, the vertebral artery, you'll see it right in that space. Big deal. So the vertebral artery right in that space, and the suboccipital nerve emerging from underneath it. The suboccipital nerve is motor only, and it's motor to these 4 muscles. So it'll go to these 4 muscles in the suboccipital region. You'll note on the dermatome chart, there wasn't any C1 dermatome. There's no C1 dermatome because the C1 here is motor only. All right. Another important nerve that I'll draw your attention to, this is the C1 dorsal ramus, special name, suboccipital nerve. This is the C2 dorsal ramus, also special name here, greater occipital nerve. So the greater occipital nerve, you'll see emerge from below obliquus capitis inferior, cross over the triangle. So here it is, crossing over the triangle, headed superiorly. It'll begin penetrating many of these muscles, including this muscle, the semispinalis capitis muscle. And it will spread over the back of your head, where it will supply skin on the back of your head. Okay, so the cutaneous innervation here on the back of your head, if you scratch the back of your head, is coming from the greater occipital nerve derivative of C2 dorsal ramus. The clinicians, so neurology and neurosurgery, get a lot of referrals about the greater occipital nerve because it's passing through muscles to get to its destination. It can become entrapped. So the trapezius muscle can entrap it, semispinalis can entrap it. So if they're having a very specific pattern in their pain, they know the anatomy, so they know where it's going, then they can go in there and release the nerve if an ultrasound suggests it's entrapped. So here's a picture in a donor that's been dissected. Here's is our triangle. Don't know why, but I've always enjoyed finding the obliquus capitis superior, the tendon on it's always very brilliant, this bright white tendon here, so we can see those three. There's a little bit of an arterial communication here coming from the vertebral artery, but I can't see the artery really well inside. And I can see greater occipital nerve coming from below, just like that spreading over the back of the head. Mm-hmm.
When you dissect it, how big is it in reality off the dissection? The greater occipital nerve, like it's really
Like spaghetti noodle.
a spaghetti
Yeah.
noodle, and that's the.
There's a lot of food analogies you get in that. See, we can all connect, right? Spaghetti, everyone knows what that is. Yeah, I would say spaghetti noodle. Arteries and nerves come in all shapes and sizes. That's I would say a medium-sized nerve, so spaghetti noodle. Big nerve, like your sciatic nerve at its origin is about as big around as your thumb. It's pretty big. That's obviously the biggest one. All right, so for cutaneous innervation, remember the dermatomes, the C2 there on the back of your head, and we know that C2 level, that dermatome level, is coming from the greater occipital nerve. We know that's the dorsal ramus of C2. Okay, so you can see that dermatome pattern going all the way down for those dorsal rami. Anterior to that little line here, more on the lateral side of your head and neck, you get into the cervical plexus, which I will not ask you about. Dr. Beeger will get you with that later. All right, so this is a little summary slide, everything you need to know, suboccipital muscles region. And remember, I give you so here's triangle, right? So borders and contents on triangle. So I would know any time anatomist, borders and contents, your ear should kind of be perking up a little bit. So that's all I've got for you today. I can stick around for a few minutes if you have questions. I would encourage you just to hang in there. Things you can do now to be successful. Things you can do now to be successful. It gets you while you still got this energy before you get all jaded and, it's coming. Just give it time. No, it'll be okay. So what I would do now is anatomy is not a monolith. And what I mean by that is every anatomy exam will feel differently on the prep side of things. The anatomy problems that you have now are simple, but a lot. The anatomy problems you have later will be a lot and a lot. Okay, so at least now the clinical reasoning and everything is pretty simple. Fracture this, process, disrupt which muscle attachment, that kind of game. But you cannot solve difficult and fun orthopedic clinical problems in MSK here without knowing the basics. Like if I were to go right now across the road, Dr. Micah Jones, but like Micah Jones, give me the innervation, tell me all about these muscles, that he would know them. You just have to know them. You can't play high-level games unless you know them. You can get to that. You can't skip it either. You can't practice question your way into proficiency. You just can't do it. So I just lean into this and become an expert. Just do it. It's fun. It's gratifying. For muscles, since it is kind of a more simple process, this is a place where, and I know it's low tech, but flashcards have a place. This is the place for them. It probably won't really help in anatomy outside of MSK, but it helps with this because, as you can see, with every single muscle, there's an origin, insertion, action, innervation. And if you can equip yourself with that very basic knowledge, then when you're asked to apply it, you're giving yourself a chance. So that's where things start. So if you can do that for every muscle, even if it's not really glorious, just write out the muscle on the back, origin, insertion, action, innervation, and you'll be in a good spot. Okay, and reach out if you have questions. Just come by and bother me at the main building. I'm in the main building if you have questions. I don't see you again I see you on Monday. I'm glad I said that. So you will get an email. I'll talk with Dr. Hill about this. To push along, you'll get an email inviting you to download some software. So the software I mentioned on day one. So this virtual human dissector software there's an element of this that's associated with every lab session. It's Dr. Beeger and I have gone through basically a whole dissection guide with it. You can do it at your own pace, so it's all integrated into the software, so we don't have to be doing it in person. So what we'll be doing, you can do it if you want, but what we'll be doing in person on Monday is going through the models. So I'll explain more about how labs work, how lab exam will work, how you can prepare for those, and we'll do our first lab. So we'll drag out the bones that we need. I'll drag out the models that we need, and we'll just kind of roll with that for a couple hours. So. Cool. Any questions? Good. It'll be okay. You guys will be okay. You have good energy. You do. You have good energy. I can just tell. I can just tell.
For the exam lecture, would we be asked, or more likely to see one dissected images, or would we see one of the like more cartoon images on
I would say I did announce this. So a couple of years ago, I went back and looked over all my test questions. On average, the test questions that I write, about a little over a third of them are associated with an image. The image is it's usually in a clinical context. So it'll be a radiograph, or it'll be like a person with a laceration in a certain location, or it'll be asking you to identify some, surface landmark or something like that. May show you an image where a person's complaining of an area of sensory loss or something like that. So it's pretty rare that I would show you like a pure, either way, I probably wouldn't show you a cadaveric image or a cartoon image with that.
For this upcoming exam, when we hear like sensory loss or something like that, skin, are you wanting us to go more towards like the domains and stuff, like locations? Is that a potential question?
Yeah, so you're thinking on the right track. So sensory loss issues could be either peripheral, so you could damage a nerve and end up with a sensory loss, or you could damage a spinal level, like with a disc herniation, and end up with a sensory loss. And you will get a lot of practice with that. So when I talk about the break, you'll get a lot of practice with that.
Sounds good. Thank you.
Okay. Okay. And you have to be careful with that. I mean, so are you double jointed? So can you we do some tests? So can you take your do you have any family with like connective tissue disorders?
Not diagnosed, but I'm on.
I think there's one for each exam.
Can you take your thumb and touch your wrist? Yeah, it can be. I mean, there's a whole spectrum of people. Some people have super tight joints. And it's all basically a combination of the fibrous joint capsule around each joint and its connective tissue profile. So if you have a lot of elastic fibers or something in there, then you may have a lot of range of motion or even the ability to dislocate.
And then 3 and 4 back to back, which is
But
weird.
it doesn't necessarily have
But
connective
it
tissue.
seems like 5 to 6 weeks.
That's all it is. So the fibrous joint capsules, of course, you have that.